All right. Hello, everyone. Great to be here. Perfect segue talking about value based care and talking about, let's make changes and interventions early and not have people end up in the emergency room. We got a lot of ER doctors here. So, I have background in biomedical engineering, went to medical school after I realized I didn't like sitting in a lab and I saw a big disconnect between what was going on with the graduate students, what they were working on, and then what was actually needed. So I decided to go to medical school, but wanted to figure out how to put it all together. And for me, part of that was coming out here for my training. I did my pediatrics residency and then pediatric cardiology fellowship at Stanford and did the Stanford Biodesign program as part of my cardiology fellowship. And it's a really unique way to, especially as a physician, but engineering side too, figure out and learn more about this. They don't teach you in medical school, about innovation. They don't teach you about devices. They don't teach you about, the business side of it. And so, getting that experience and, what they emphasize is needs-based innovation. So it's not come up with something cool and then try to find a need for it. It's figure out what is a real clinical need, understand that need inside and out, and then start to invent. And that's when you're going to be successful. And so this company, this need was identified in the fellowship, and we, really have taken it from there. And it was too good for me to resist. So I am practicing, but just a half day a week at Stanford, and this is what I'm doing. And then on top of it, that's my daughter, who's 4, bootstrapping it. This is Christmas card photos. But she also has given me the experience of treating children with asthma as a physician, but also as a parent. And so, I come with this really unique perspective on how we can do it better. So, when we were looking at asthma as one of the things we were identifying and delving into in the Biodesign Fellowship, some of the staggering facts are that 50%, some studies say even more than that, of patients are not well controlled. And why is that? Obviously you can't simplify to just one thing, but we realize this lack of an objective indicator is so challenging. How are you supposed to manage a chronic disease when you don't know how to assess it? There are medications there. So yes, there's not a cure for asthma. That would be great. But there is the belief that every patient should be able to be controlled, but we don't know how to measure it. So how do we do that? And that results in very poor adherence. Again, when you don't have a measure, people don't see what happens with that. It's a very costly problem. These numbers are US alone, 37 billion for asthma. And 2/3 of that are hospital-based, which shouldn't happen ever, or at least rarely. We don't want people to go to the emergency room for asthma. We don't want them to end up in the hospital. Here's just a quote from a recent review article summarizing that asthma control is important, and then in the very next sentence saying there is no universal measure of control. So, okay, great, we need to control it, but we don't know how to measure that. And, so when I first started actually talking about this company, and particularly to investors, I realized I actually have to educate a little bit about asthma because everyone thinks, oh, asthma comes out of nowhere. You have an exacerbation. There's nothing you can do. Treat them in the ER, treat them in the hospital. So really need to, make people aware of this control, this factor or idea that there is a level of asthma control, and that's what we want to target. We don't want to just treat exacerbations. I want there not to be any exacerbations. So this is NIH guidelines, says that at every clinic visit, a physician should put the patient into one of 3 buckets: well controlled, not well, or very poorly controlled. Why only 3 buckets? Well, we don't have good ways to measure it. So that's, as good as we can get. They then adjust the medications based on that assessment. They give an asthma action plan so the families at home knows if you're in the green zone with no symptoms, here's the medication you take. Yellow zone with some symptoms, likely increase it as prescribed. And then red is kind of danger, call or go to the emergency room. And that's very stressful at home. You don't have good tools. You're trying to monitor symptoms. They're very subjective. And again, this idea, most people know about exacerbations, but they think that's all there is, and there's not. When you're in that not well-controlled state, you're more likely to have an exacerbation. So if you have a trigger, then you go into that exacerbation. Well, if you're in that well-controlled state, you're a lot less likely, even if you have that trigger. And again, I'm hammering this point home, but it is important. What do we use to measure that? Subjective recall is the primary thing. So asking people about their symptoms and asking them to recall over the prior weeks. And very subjective. There are patients that are under-perceivers, so they actually don't realize when they have symptoms. And then other people that are over-perceivers and think things that aren't actually asthma symptoms are asthma. And just a little schematic. So imagine you could look at this. These are, say your survey, you got survey scores over time, and maybe this patient's, doing pretty well. Then you look, what is that? What if you had daily measures? Then you can actually see what's going on. You can see, wow, actually, they're not doing well at all. It's completely different than little snapshots. And I have to show this. This is NIH guidelines assessment of control. This is for pediatrics, so there's the different ages. There's all these different things you're supposed to look at. And why are there so many things? Because we don't really know what to measure. So they're pretty much all symptoms besides lung function tests. So asking symptoms in lots of different ways. And compare this to diabetes, another chronic disease. You have a glucometer. You have hemoglobin A1C. You actually now have continuous glucometer. So they're totally different diseases, but the idea is we do not have a glucometer equivalent for asthma. We do not have a good way to measure control. And so that is what we're doing. So we are defining a digital biomarker, and I'll go into that a little bit more, but using passive nocturnal monitoring to give this daily assessment of asthma control. And then we want to take it that step further. Data alone doesn't change outcomes. We want to close that loop and really make sure that with that data, we get better outcomes. So data can be viewed by the family with a mobile application. We reach out and get additional context, and then we can follow guidelines, point them to taking their medications, consulting their asthma action plans, discussing triggers, have an asthma coach help out, and then help them know when they should reach out to the physician. We're not trying to replace them. We're trying to augment and be a better tool for the families. The device we're using is off-the-shelf device, and we're device agnostic, so we can use other devices. Right now, the one we have is made by Murata. They make accelerometers for the iPhone, and this is accelerometer-based technology. Goes on the mattress, so not a wearable, not something you have to put on. Measuring the small vibrations, you can get movement, so surrogates of sleep quality, but you also can get heart rate variability, respiratory rate, and other physiologic measures, all from the movements and from the scientific principle of ballistocardiography. So every time your heart's beating, there's a characteristic vibration. Really important, we felt when we were thinking through this, that it needed to be passive, that something like peak flow meters or things that have you do extra step in your day is a challenge. It's not something that everyone can do. We want something that's passive, that when people have kind of forgotten about asthma, forgotten maybe to take their medications, and are a little bit off the charts and wouldn't be doing the peak flow, we're going to catch that. We're going to be able to reach out early and show them what's going on. We started a study over a year ago at Stanford where we were doing observational, so placing these devices on the beds of children who had moderate to severe asthma, collecting this data, collecting the validated surveys, getting all the status reports, all the measures that we have these days, and have built our initial analytics off that. One abstract presented last year showing that there were changes in heart rate days before exacerbations, and then being presented next month at ATS showing heart rate correlating, not just multiple different parameters of heart rate correlating with asthma control. Then, as I said, closing the loop is important. Education alone matters. Education tied to data, knowing then who should you reach out to, what's the appropriate time, and having families who are motivated because you're showing them that something's actually going on with their child, or if it's an adult, with themselves. In diabetes, we see this in the pre-diabetes space, and again, they had tools and things that they had measured. So we're creating this digital biomarker and then using that same model. We can reach out early on. This is, just kind of showing control in a patient that ultimately went into an exacerbation. Well, we want to find out what's happening, whether it's they stop taking their medication or there's a trigger, or they're not on the right medication. Let's make that change so they don't end up in your emergency room. Just a great example showing how data-driven management can save money. This is a very invasive device. I feel pretty much the opposite of placing a sensor on the bed where it doesn't even have to touch you. Implanting something where you're measuring pulmonary artery pressure to help manage heart failure. So this is a cost-effective, cheap thing that we can do. But the same idea, that how do we change management based on a parameter? Here, just thought you'd like to see some data. So this is a patient who is in our observational study. So we have the alerts going, but they're not going to the patient right now. We have our compilation score, same with the asthma action plan, a red, yellow, green zone. This patient was well controlled initially and then had 2 periods where they went into the yellow zone, alerts both times. In both of these cases, this is a very observant mom, so she was on top of it. She didn't know we had those alerts go off, but she said one day after the one and 2 days after the other, oh yeah, my daughter's having some symptoms. We changed the medications, increased the dose as prescribed, and she regained control. So myself included, I feel not every mom can be quite as observant as this mom. And so having this alert to say, okay, pay attention. Is there anything going on? Make a change based on the asthma action plan if there is great. But even the same mom who's very observant doesn't know between severity. So she then had another symptoms. We had alert and we knew that this was different another time. This was not the same thing that she had before. And she never really got back solidly into the well-controlled. Had another trigger with a virus and ended up in the emergency room. So this is where it shows that having an objective measure and really understanding scale and making sure that your child gets back to a well-controlled state before making changes would be valuable. Just in contrast, another patient in the study who's been rock solid stable, no symptoms at all, and we haven't had any alerts go off. Big value proposition, as was discussed, the care. So these are for moderate to severe asthmatics. If you take them from not well controlled to well controlled, it's over $4,000 cost savings per year. And unlike diabetes or prediabetes, where absolutely there's clear value, you have to wait a while to see it. So sometimes it can be hard to convince insurance companies to pay for that. In asthma, you'll actually see those cost savings that same year if you're able to help them regain control. You've already met me, so I have two other co-founders, both of which that I met through the Biodesign Fellowship. Both of them are engineers. Mike also has an MD degree. He went to UCSF after being in consumer electronics for a while, got the medical degree as his kind of move into med tech. And that's it. What questions do people have? Mm-hmm. Yeah, so question of medication adherence. So we are not directly measuring medication adherence. So there are lots of, as I'm sure everyone has heard, lots of inhaler devices out there that will measure that. We absolutely could partner with one of those to get that specific information. What we are measuring, though, is effect. So, those devices on their own just measure whether that device has been pushed. It's not measuring, is the technique appropriately, is that patient actually, improved by it. So more in, the affecting adherence is the fact that, hey, we've noticed the change. Have you been missing any doses on medication? So again, if you're just tracking whether they're taking it or not, absolutely, whether they are or not necessarily whether it got into their lungs and is affecting. And you can then track that and tell someone, oh, you haven't reached, the 90% goal that we have. But all you can really use to motivate them is, well, you haven't done this. Well, we have the data to say, look, there's a change. So if you haven't been taking it, here's why you should take it. Yeah, so question, consumer product or billing for CPT codes? Great question. We likely will start consumer just for a little bit, really, because you can get out there quickly, get more data, really show the value that the individuals feel from it. But ultimately, we want this paid for. That the big value proposition for the moderate to severes are from the payer side or integrated health network. There might be in the future, kind of for mild asthmatics where it's not going to get paid for. There's a light version and a plus version. It likely won't be CPT codes. We've looked into that, but it really is the value based, the per patient, per month, or per year care and management. Got lots of hands. Mm-hmm. Mm. Yeah. Yeah, no, absolutely. And diabetes, I don't think that this would be a good one for that. There is congestive heart failure. So anything where you'll see physiologic changes, and then again, this isn't for a sudden that, okay, if you need a response in the middle of the night, that's not the goal for this. So allergies, yes, absolutely. I think that would likely be more consumer products. Depending on how expensive the meds, it's less of a payer side, but absolutely. I mean, from movement, poor sleep quality, heart rate, with asthma and with allergies, that you're in an inflamed state. And so we can see that. Yes, absolutely. Allergies is another good space for that. Scale it. So question about how are we going to scale the business? So, in terms of, we have analytics, so devices are off the shelf. So those can be, shipped out and sent to them. Um, really the big thing is getting contracts and getting, whether it's, ultimately to get 5 million, the payers, or, if you get Medicaid has all of their patients who have moderate to severe asthma. And then in terms of scaling, from the data side, that's not a complex. Obviously, I'm not the one actually doing that, but Amazon Web Servers, and we have that's not a large thing. What we have, most of the process is automated. So when there is kind of an alert or a trigger, we're reaching out, we're finding out, first of all, is there something else going on? So is there a gastro or something else? But going through an automated thing, and then there are asthma coaches that can be available. Those are if you want to talk and discuss further, not in real time, not replacing the doctor. So those costs are pretty low, and we have surrogates of different studies showing how much time you would need from them. Mm-hmm. 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 So how to scale basically the sales to the business. Yeah. So, I think some of it is really actually, though, getting that clinical side and getting it that this is the way that you measure asthma control to become a gold standard in that. But then also data showing outcomes, that if you really have the study showing that you change outcomes, absolutely, payers hear all sorts of people coming to them. But if you have data showing them that you can save them money, then they're willing to try. Usually it starts small and then roll out from there. So, we're talking to Sutter, we're talking to lots of different ones now, and everyone's interested. They find this interesting, they get it. It makes sense. But yeah, we have to prove that it works, that it actually changes outcomes. So, you do a few of those, and then you don't keep proving it again and again and again. You prove a couple of them with the big names, and there you go. It's going to be easy, I think, right? Yeah. Mhm. Yeah, so very interesting, asking if we know what the triggers are. So we haven't incorporated yet, but absolutely, GPS data, weather, allergen data, there's a lot of data that we can pull in. And if we know kind of someone's allergy testing. So we will work on having some of that known. We also, in our automated process, find out, did they have a cold? Were there certain triggers that they can report to us? The more of that we can automate, the better. And then again, just because you had a trigger, even if you have seasonal allergies and this pollen is out, it doesn't mean you have to go into an exacerbation state. But yeah, if we're seeing small changes, then it likely is related to that. Yeah. Yeah. Mm-hmm. 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 Yeah. Yeah. Mm-hmm. Yeah. So asking about, emotional stressors for asthma. And so we're getting those self-reported right now. So we are asking about it, because absolutely stress, emotional midterms time, we've seen that in some of the patients. Mm-hmm. Yeah, great. So how do we define the threshold? So, proprietary, the specifics of it. There's a 2-week learning period. It also, the pediatrics, you have to, age and size helps us kind of with that initial. It really hones in those 2 weeks. So the specific threshold is patient specific, but we have, kind of our overall algorithm that it starts with. No, Yep. So question, is it measuring just the heart rate? No, there's actually 10 parameters that output from that device. So from the movement, and so from that you can look at sleep and kind of in bed, how much sleep time, how many awakenings when they get out of bed, those type of things. There's heart rate variability, respiratory rate. There's actually stroke volume, cardiac output. So a lot of different parameters, not just heart rate. We've been focusing on kind of the clinical literature on getting it out there, this idea that heart rate can be used as part of assessment of asthma control. Really, in the getting the buy-in, it's a little bit tough because want to, this is actually part of kind of biodesign and the thinking of you need the business. This is one of those things where I could get a great algorithm. Here's this biomarker for asthma and publish it. It'd be this great article. But if there's then no company that's actually doing that to make it happen, then that's not going to do anything. So we're balancing. We want to, do everything the right way. We want to do the studies the right way, show this, get the clinicians on board, but we also have to have a business around it. And so there's some proprietary aspect to, specifically what we're doing. You go to our website and you can put your name in, just an email, and I can let you know as soon as, should be doing beta testing in the summer. Yep. 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 Yeah. Yep. So ask about the name. What does Tueo mean? So tueor in Latin means to observe or to protect. So we were, trying to think of something sort of not specific disease, and just the idea of watching, but not in a creepy way. So yeah, observer to protect. And Tueo is just an alternative version that sounded nicer than tueor. So there you go. Mm-hmm. Yeah, good question. So what age group could this be used in adults? Yes, it absolutely could be used in adults. In our study, the youngest we had was 5. Younger than 5, the diagnosis of asthma is, not as clear. And actually, when you're really small, you were measuring vibrations, although I do have this on my 18 months old bed, and it can pick up, but it's harder on the younger side. So not below 5. And then we've gone up to 18, which an 18-year-old, is the same as a 24-year-old. So as long as you're not having, arrhythmias or a something where your sinus node doesn't respond. So I don't know kind of at what age in adulthood, because I just take care of pediatric cardiac patients, not adults, but that, at some age, it's not going to work as well when the sinus node really isn't responding the same. Great. Thank you, guys.